Brighten a little bit brighter.
Yeah, you would have to break
Is that better?
Yeah.
Should I make it brighter still?
A little bit.
Oh, that's good. Oh, you're right. That is better. So, the uterus, I should show it like here, is in the pelvic cavity, just like this. It's kind of extraperitoneal, because some of it bulges into the peritoneal cavity, but the lower half is definitely retroperitoneal down here. There's no peritoneum touching it. The upper half is kind of bulging in, but it doesn't need mesentery. More or less, it's retroperitoneal. Some books might call it intraperitoneal. But it's not listed as part of those sad pucker thing, which has it part of real retro. The rectum is retroperitoneal right there, completely. But we'll consider all of this retroperitoneal except for the ovaries. That's within the peritoneal cavity. That has real visceral peritoneum surrounding it. Meantime, the parietal peritoneal drapes over all of this. And if the uterus is like this, it's like putting a blanket over me. This part here is the fundus of the uterus. From here to here is the body of the uterus. And this little squiggly part that's tight in there, that's the cervix. It has an internal sphincter and an external sphincter called the os. That's what the doctor looks at when he sees if you should push yet. Is it 2 fingers or 3 fingers? How dilated did the os become of the cervix? So you look at cervix dilation through here to see if it's safe to push the baby out. So the cervix bulges into this, which is the vagina, and the lateral recesses of the vagina on either side of the cervix are called the fornix. If we look at the external genitalia, what became the scrotum on the male is a fold on the female with fat inside it and hair on the outside. That's the labia majora, or labia majus, this is called. If you spread those lips apart, there's another fold of fatty skin that doesn't have hair. That's the labia minus, or minora. And that leads to a thing called the vestibule. This is called the vestibular gland, but this is the vestibule. There are glands in here that lubricate it. In the vestibule, the most anterior portion is analogous to the glans penis on the male. It's the clitoris. It's erectile tissue. It's like the cavernosum, or the spongy cavernosum that swells out, and it's very sensitive with nerve endings like the glans penis. And it's covered with a prepuce of the clitoris, being part of that labia minora. If you go posterior from there, you have your bladder, and females only have a short urethra. So a urologist just handles the bladder and the urethra in the female. It takes a gynecologist to work on this part, the vagina and the uterus and the ovaries. In the male, it's all handled by a urologist. There's a separate opening for the reproductive tract, not so in a male. Plus, in a male, when sperm is made, it's all in a closed system. The ovary is not, when it produces an egg, it's not in a closed system. It's out here in the pelvic cavity, and when the egg is released, these little hair-like structures, fimbria, produce a current so that it sweeps the egg into the oviduct. But it might not land there. It's not quite a closed system. So the oviduct is called fallopian tube, it's called oviduct, it's called uterine tube, and it's called salpinx. You can use any of those names. They have a lot of names for that, whatever you're most comfortable with. Salpinx, fallopian tube, uterine tube, or oviduct. The uterus is prevented from tipping so far back, it tends to have anteversion over the bladder. This is the anterior of the body, that's the posterior with the sacrum. There is a round ligament that goes from the anterior portion near the fundus of the uterus and goes through the inguinal canal and prevents that from tipping back. And then there is a uterosacral ligament going from the back part of the uterus back to the sacrum, prevents it from tipping too far forward. The peritoneum that drapes over the uterus and oviduct is the real ligament that supports the uterus, and that's called the broad ligament. This here is a fold of peritoneum. Parietal peritoneum just folds over this, and it's known as the broad ligament. And serosal membranes are called mesothelium in general. The pericardium is a mesothelium, the pleura is a mesothelium, the peritoneum is a mesothelium. So they break up the broad ligament into different mesoparts. Mesosalpinx wraps over the oviduct or the salpinx and stabilizes it. Mesovarium is behind the ovary and helps stabilize the ovary. And mesometrium stabilizes the uterus. It prevents it from moving to the right or the left, holds it in place. And why is it called metrium? There are 3 parts to the uterus. Histologically, the innermost is an endometrium. Then you have something called a myometrium. That's the muscular layer. And the outside is a perimetrium. Perimetrium just blends with that mesometrium. Endometrium is what's sensitive to estrogen on the female. So every month, the FSH from the pituitary in a female brain is released in cycles. On a male, it's just constant releasing FSH and LH, but it's cyclic on a female. And when FSH is released, the eggs in the ovary will start to develop, and the follicle cells that surround them start secreting estrogen. The estrogen causes the endometrium to thicken. The endometrium sits on a basement membrane. There's a stratum basalis that's always there. But once estrogen comes, the stratum basalis becomes very mitotically active, and we get this thick layer of a stratum functionalis. So more and more estrogen comes there. The endometrium goes from being very thin, just the stratum basale, to now having the stratum basale plus a thicker and thicker stratum functionalis. This is where an egg that's fertilized, a zygote, will develop. It doesn't develop in the lumen of the uterus, it burrows into the endometrium. It goes all the way into the endometrium wall, and then that endometrium wall expands out to almost close, and you obliterate the lumen. But it doesn't develop in the lumen, it develops inside the wall of the endometrium. And once the egg is ovulated, progesterone levels get high. Now the stratum functionalis gets more blood vessels and more glands. So it becomes lush and secretory. Makes it easier for a zygote to kind of burrow right in there and get nutrients. So if at the end of a month, a zygote didn't burrow in there, now the progesterone that was made by that corpus luteum, that we mentioned in class, corpus luteum just dissolves. It's gone. And if that was to occur, now progesterone dies off. And the arteries that were fueling all of those glands and blood vessels start to tighten up. And all the stratum functionalis becomes necrotic and just falls away and becomes sloughed off. And the arteries that are there, just arterioles, just the blood, all leaves here. That's menses. Menses occurs in the uterus from the stratum functionalis of endometrium being sloughed off, and all you're left with is a stratum basale until the next cycle begins and the endometrial line proliferates again. So it's sloughed off here, and the vagina just acts as a conduit, just lets all that garbage out. Some people get painful menses every month. Some people doesn't bother them. But very common in women is they might have pieces of endometrium that normally occur in the uterus just so happen to get up here in the fallopian tube, or maybe on top of the ovary, or maybe on the back wall of the rectum, because it's close to that. Now, once a month, when FSH is released and estrogen levels get high, the tissues, wherever they are, start to proliferate, and they become very thick and heavy. And when progesterone comes, they become glandular. Now, when progesterone dies, the tissue becomes necrotic, but if it's in the ovary or the rectum, it can't really leave as easy. It can't be flushed out. So instead it becomes stuck in here, and it becomes scar tissue, and it adheres the walls of the oviduct and clogs it up, or adheres the ovaries to the rectum, or other structures, intestines. What's that affliction known as? Those painful menses when the endometrium are giving women a problem? Some of you have had a hair of it. Take a guess. What? Endometriosis. That's endometriosis. It's just the fact that the endometrium that's supposed to be in your uterus, there's endometrial tissue elsewhere. And it wouldn't be so bad if during menses it can just be swept out, but it can't be swept out. So it stays there and clogs up. It's like the #1 cause of infertility in females, because now all of a sudden you clog the uterine tube. So the sperm can't get there. When the egg is released, it's released from something called the Graafian follicle, and we did this in class, and we'll go over it again in class. The fimbria will create a current so that when it's released, it travels into the oviduct. The first part is the infundibulum, then the ampulla, and then this tight portion, the isthmus. That's the 3 parts of the oviduct: infundibulum, ampulla, and isthmus. That egg is viable for about 1 day. So a day after its release, if we go 2 days, that egg can't be fertilized. So that you only have 1 day to fertilize that egg. The sperm might be there a day or 2 before, because sperm can live a while. And it might get there the day after with intercourse. But the egg is only good for 1 day. It's a 4 to 5 day journey down the oviduct. So if I ask a question, where does fertilization occur? It has to be inside the oviduct. It's going to travel in that oviduct for 4 or 5 days. After the first day, it's not viable anymore. It can't be fertilized. So if it's going to be fertilized, it's got to be fertilized inside this oviduct. And if you have endometriosis that clogged up the oviduct, you can't become pregnant. Or worse yet, it's small enough, sperm small enough to get through here, you fertilize the egg, and it starts to try and go down, and the egg can't pass through. Now you get a tubal pregnancy. That can result in death of the female because the tube might expand and burst. In order to have a successful pregnancy, the egg has to come into the uterus. It either burrows into the body or the fundus. It shouldn't be too close to the cervix, or then it's going to widen the cervix and you won't be able to hold the pregnancy. It's got to burrow either in the body or the fundus to have a successful pregnancy. And if some women are having trouble getting pregnant, one of the things they do to test to see if it's the endometriosis is they put them on a table, put them upside down, and infuse under high pressure through the vagina some dye. And then they take radiographs, and they see that the dye travels here and stops. Now they know that it's clogged right here. Typically, when they give the dye, it should spread out throughout the pelvis, because it comes out here and then goes out the infundibulum into the pelvic cavity, if it's clear. If you have a sexually transmitted disease in a female, it could travel from the uterus, the oviduct, and then come out into the pelvic region. That's known as pelvic inflammatory disease. Because this over here is a weakness, it's a potential opening into the pelvis. This is within the pelvic cavity. This is kind of retroperitoneal. So the ovary is one of the structures within the peritoneal cavity, and that's why you can sometimes get pelvic inflammatory diseases from that, from sexually transmitted diseases. This picture I don't really have to show. We'll look at it on the other side. It just shows the external genitalia. When I first was studying this a few years back, and I had my first lab in it, I was lying in bed looking at this, and my wife kept looking over my shoulder saying, "When are you getting off that page?"